So do you have a preferred regimen for initial therapy?
That's a great point. So we always, traditionally, we have a plethora, I will used to say, shopping list of really different kind of regimens that we can use. Since the last NCCN guidelines, really I have to say that because the very, very important phase 3 clinical trial that was reported and asked previously, right now BTK inhibitors, in this case ibrutinib, is become almost the standard of care in any kind of CLL. And we are talking about younger, older, with or without comorbid condition or independently of the stratification. That's for sure, right? However, we still have our all chemoimmunotherapy that is fading away but still present, right? And the new therapies that we'll discuss later that just presented at this ASCO meeting. I think what I really try to understand is what the patient's goals to really therapy, and also the needs and the different side effects profiles that new medication and old medication may have, long-term duration of therapy, short-term duration, and then I have this conversation with my patient who require therapy to really customize in somewhat really the best therapy for each patient. However, we need to recognize the data, and right now the data is very, very strong for really targeted therapies.
Now, the Alliance-led intergroup trial looked at older patients where patients were randomized between BR, ibrutinib, rituximab. There was really no difference between the ibrutinib-containing arms, but they showed an improvement in progression-free survival. In the younger patients, the ECOG-led intergroup trial was FCR versus ibrutinib, rituximab. Again, an improvement in progression-free survival. And in a subset, the unmutated, it looked like there might be a survival benefit as well.
Well, in fact, the survival is in the overall group, right?
Yes.
When you really differentiate the mutated and unmutated, obviously, as we predicted, mutated patients still may do well with FCR. However, you expose those patients to chemotherapy, and not all of them they are going to do well with FCR. It's important. The unmutated is obviously the one that we knew for a long time that they will really much benefit for these new therapies.
So let me put you on the spot. You have a young patient who has mutated CLL. How much of a discussion do you have about FCR versus ibrutinib-based regimens?
So it's a great question, and we've been evolving in the last 3 years. I will start to use ibrutinib in unmutated younger patient for a while because we already knew the data coming from FCR regimens that unmutated patients will relapse shortly, and those patients are the ones who may also have clonal evolution induced by a chemotherapy or by this famous bottleneck that will really be induced by the shrinkage of the cells, right? And you may have one TP53 that will come up. So I think it's important. However, now with the recent approval of venetoclax Frontline, we have very fortunate to really discuss even more options for the patient, even from younger patients with unmutated immunoglobulin.
Well, before we get to that,
Sure.
Does the status of P53 actually mutation or deletion, does that affect your initial treatment decision?
Well, what we know for sure, and we know this for a long time, that patients with deletion of 17p or TP53 mutation should not receive any type of chemotherapy agents, because chemotherapy we know doesn't work and really make things worse in the long run. So on those patients, for sure, standard of care has been ibrutinib. Obviously, new therapies, as the one that we're going to discuss later, is going to be introduced, and it's very, very important. But those patients, I think, I always really don't really hesitate to really reinforce the fact that those patients should not receive chemotherapy of any type, no bendamustine, no fludarabine.
Okay, Javier, I get it. You're really eager to talk about venetoclax and BCL2
Sure.
inhibition. So let's start with, what is the role of BCL2 in the pathogenesis of CLL?
So I think it's fascinating, and the last year we start to understand the physiopathology of CLL, right? We know that CLL, they have these two components, right? One side, they proliferate through the BCR signaling, and this is the signaling that we can really block through BTK inhibition or PI3K delta inhibition, right? So we block proliferation. But we know that it's not the only mechanism of CLL that really have to survive. So we know that, as differentially happen with AML, acute myeloid leukemia, those patients don't grow slowly over time, right? But what is happening is that there's a slow growth of germinal centers, bone marrow, but at the end of the day, what's happening is these cells that grow don't die. So why they don't die? Because they upregulate BCL2, that we know is an anti-apoptotic protein that really stops cells to die. So we have these two amazing mechanisms on place. And what is really, really exciting that today we have the two main mechanisms to really fight CLL, the blocking of the proliferative and really the blockade of the anti-apoptotic protein. So when we block the anti-apoptotic protein, obviously cells massively go to destruction and they're gonna die.
Well, I think that's the fascinating clinical observation, right? It's the rapidity with which you just block BCL2 and then the cells die. So how are these cells poised to die? I mean, you just block BCL2. Why is there just massive apoptosis at that point?
Well, the reason is because when you block the anti-apoptotic proteins, there is another pro-apoptotic proteins that take place, that is a disbalance. So you disbalance this mechanism, so cells really will enter in this natural way that the cells have to really go to apoptosis, right? So the BCL2 upregulation is what is disbalancing the fact that those cells may be dying and they don't. So when you really block these proteins, allow cells to really continue the normal process of apoptosis.